abortion, but the abortion has become associated only with elective abortion. So they used to use the term spontaneous abortion. Now they've just gotten rid of that and they just refer to it as miscarriage or your ectopic pregnancy. I am not attempting to downplay the mental, emotional, or physical effects of a miscarriage on one or both parties involved in the relationship. However, between miscarriage and ectopic, only one of them can kill you. So with your miscarriages, look at those signs and symptoms associated with. Even a difference between the two as you look at that, bilateral lower abdominal pain, bleeding, passing some clots, or cramping. When you get into the ectopic, instead of bilateral, it's now one side versus the other. Not a whole lot of bleeding, but usually severe pain, syncopal episodes, shock-like symptoms if this were to rupture. Okay, so ectopic in medical speak simply means outside. So an ectopic pregnancy, it could be tubal, it could be ovarian, lots of different places that it could implant, but it simply means it's somewhere that it's not supposed to be. All right, this is usually also a very rapid onset and rapid transport, paying attention for signs and symptoms of shock. Now, our late trimester concerns, usually abruptio placenta or placenta previa. Okay, with the placenta abruptio, because this is a cephalic birthing position, the placenta is typically opposite of where the head is. So the placenta is up high, meaning that it's got a long way to travel. All of this blood here, right? All of that blood here has to take a while to travel down before it gets outside. So we think dark red, bright red. Dark red. Okay. So dark red bleeding, tearing style of pain, placenta abruptio. Now your placenta previa, this is typically your breech presentation. So baby's up here, placenta down here. Okay. Also, not usually a whole lot of pain associated with, and in fact might even be referred to as no pain, but now bright red bleeding because of how close we are to the exit. So late trimester, dark red bleeding, tearing style pain, placenta abruptio. Late term pregnancy, bleeding, bright red bleeding, very minimal pain associated, even referred to as no pain. I'm going to look at placenta previa. All right, this is our supine hypotensive syndrome, which is exactly as complicated as it sounds. Blood pressure drops when they're laying flat. What's going to be our treatment for this? Left lateral recumbent, right? What if you're doing full SMR procedure and the patient's on a long spine board with a C-collar? Bingo, bingo. Prop up the right side of the board, alleviate some pressure along that spinal cord or along that vena cava, allowing for appropriate blood flow. Understand the difference between your preeclampsia versus eclampsia. So preeclampsia is hypertensive syndrome of pregnancy. Right? These are usually very late trimester concerns. Signs and symptoms can be a little bit similar. So hypertension, swelling of the hands and feet, epigastric pain, all that kind of fun stuff. That's all preeclampsia. Eclampsia is the actual seizure. Right? And the treatment is very similar to any other seizure, but we're going to add a medication to the treatment of such eclamptic seizure, which is mag sulfate, right? Why mag sulfate, not a benzodiazepine? %. Okay, so don't ever let anybody tell you that mag sulfate doesn't cross the placental barrier, because everything crosses the placental barrier. But what do we think is going to be more dangerous? Plopping an electrolyte into this lovely young lady who's having these issues, or a benzo that's going to slow everything down for both patient and baby/fetus? So everything crosses the placental barrier, but the mag sulfate is the safer of the options, and it is directed more towards specific treatment versus just stopping the seizure. With our field delivery, straight off the nremt skill sheet, no tricks. Study that nremt skill sheet, both the normal and the abnormal. I believe those are part of the packet that we send to you secondarily. But it's information that you got to know. Okay, same thing. BSI scene safety, number and location of patients, MOI versus NOI, blah, 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 blah. And then get right into that field delivery procedure. Okay. Now, some of the complications that can pop up in questions from time to time with childbirth, something like a breech delivery. This is usually going to be some type of rapid transport to the appropriate facility. This is one of the situations when something that is attached to you may need to be inserted into a patient. So if we do have the presentation like the situation on the left, what's our treatment? Just like the picture on the right, 2 fingers into the vagina, alleviating some pressure and basically making room for the nose and mouth of that child, combined with rapid transport. All right, now this is where you get your EMT on the truck involved, because I'll tell you, it has 2 thumbs up and isn't gonna take the whole ride to the hospital with my fingers inside a patient is this guy right here. All right, so I'm not getting tied to that. That's the lucky position that I have, is I get to step outside of the truck and go, hey, you guys good? All right, cool, I'm out, see you. All right, but 2 fingers inserted into the vagina, creating that V to alleviate pressure off of the nose and mouth of the baby/fetus, giving them the opportunity to breathe on their own. Same thing with the prolapse cord, 2 fingers into the vagina. Ideally, if their birth is not imminent, putting them in that left lateral recumbent position or that knees to chest upright position, and then 2 fingers into the vagina to alleviate pressure on the cord, because if nothing of the baby has come out yet, how are they breathing? They're breathing through that cord. If there's a lot of pressure on the cord, they're not getting blood flow, they're not getting oxygen. All right, here's our shoulder dystocia. It's associated with Mick Roberts maneuver, and Mick Roberts maneuver is only associated with shoulder dystocia. And again, this is straight off of the abnormal delivery and our EMT skill sheet, no tricks. With our neonatology, as we make our way over, I believe we are down into page 81 over into page 82. So understand the basics. APGAR score question is unbelievably common. You must know your APGAR score. Okay, you may be the type of person that only gets 1 OB question on your test, and if you do, it's probably going to be an APGAR score question. All right, so this is information that you absolutely 100% must know. Same thing with your inverted resuscitation triangle. All right, so dry, warm, stimulate, all that kind of fun stuff. Super basic information. Okay. These are our congenital abnormalities. Again, not common questions, but cleft lip, cleft palate. All right, now there's an oxygenation concern because there is no separation between the oral and nasal pharynx. This is your Pierre-Robin syndrome. It's a severely deformed lower jaw or mandible, causing a potential pinch point at the back of their oral and nasal pharynx, causing them to have some difficulty breathing. This is usually a question where it's just a straight up assessment level question. They want you to understand what this is so that you can move forward. This is your spina bifida, where most of the spinal column doesn't close all the way and potentially born with nerve clusters outside of the channels that they're supposed to travel in. These, again, assessment level questions. This is just understanding these medical terms. Here's our pyloric stenosis. All right, so kind of keep in mind the term sphincter. I know it's fun to say, and you're allowed to giggle every time you have to say sphincter, but remember, all sphincter means is something that opens and closes. So you got lots of them in our body. All right, pyloric stenosis is the bottom level of the stomach that leads into the intestines. Stenosis is the hardening of the pyloric sphincter. No, it's not true. Stenosis is hardening of anything, but pyloric stenosis hardening of the pyloric sphincter, meaning that it can't open and close very well. So that you now run the risk of intestinal contents pushing back into the stomach. Typically, the descriptive term that they'll put in the question is forceful vomiting. All right, let's practice. So a 33-year-old woman complains of unilateral lower abdominal pain. Most important differential diagnosis to rule out would be I like A alpha. Okay, I look at all of those answers and they're all bad, but there's only one of them that could potentially kill the patient right away. Second stage of labor ends with C. Charlie, right? Now, personally, this is just a personal thing. I don't like the way that they changed it. I liked it the way that they referred to it before, because the term used to be expulsion of the infant, and that always made me think of them like freaking shooting out like they were on a slip and slide, and it always made me giggle. Expulsion of the infant. But delivery of the infant, third stage ends with delivery of the placenta or the afterbirth, right? OB patient tells you that she has hypertensive syndrome of pregnancy. Choose 3 signs or symptoms of this condition.
C.
D, B, C, and D. I like B, C, and D, right? So right there in the term hypertensive syndrome, boom, hypertension all day long, increased protein in the urine, and excessive swelling in the hands. It's basically for those of you guys that are in Milwaukee, we're in South Florida here. So anytime I have one of the lovely Puerto Rican ladies that works for our fire department and she's cooking that day, I know I got to get the extra large gloves instead of the large gloves because my hands are going to swell with the amount of salt that goes in that food. So excessive swelling of the hands, increased protein in the urine, all secondary to salt retention and hypertension. Delivering a baby whose body came out first and the head is now stuck. Appropriate management for this patient includes all except C. Charlie McRoberts maneuver is only indicated for shoulder dystocia. You perform an APGAR score on a newborn. Findings: breasts of 20 and irregular, completely blue, pulse 80, some flexion, weak cry. What's this baby's score? Cinco. I get a 4 because you basically get 1s across the board with the exception of the appearance gets a 0 because they told you completely blue. So that gives you a 0 and then 4 1s. Newborn has a heart rate of 50. What is your first action? Yeah. Remember our inverted neonatal resuscitation triangle. So what happens there, the key word is this guy right here. I know most of us are going to revert back to our BLS training and say that a heart rate less than 60 starts chest compressions. That is for infant CPR, not neonatal resuscitation. Remember, neonate and infant, those are 2 different terms. So dry, warm, stimulate. Patient, you're called to the scene of a 9-month pregnant patient. She's having tearing pain in the abdomen and some dark red bleeding. What's her most likely diagnosis? Abruptio placenta or placenta abruptio, however you want to term it, is perfectly fine. A delivery in which the buttocks comes out first. That's breech, right? Anything that's not head first is breech. All of the following are true regarding maternal cardiac arrest except A alpha. ACLS drugs cut in half, nothing to do with maternal cardiac arrest because you're going to treat that exactly the way that you would any other cardiac arrest, with a couple of other little tidbits of wisdom. I guess I just gave this one to you. What's the sign of pyloric stenosis? Forceful vomiting, right? All right, so every day we need to be on that LC ready, getting prepped and set ready for this test so that we can nail that one and done way of thinking. All right, so, all right, app product. All right, there we go. So thank you guys for your time. We're going to do it again, same bat time, same bat channel, first thing tomorrow morning. For those of us on Eastern Daylight Time, 9 a.m. Those of you guys off in Milwaukee, Algonquin for the good land. 8 a.m. I would imagine for you guys because you guys are Central Standard, right? All right, cool. So same bat time, same bat channel tomorrow. And again, kind of remember how we started to pick up speed towards the end of the program here today. We're going to really hit the ground running first thing tomorrow morning because we've already taken care of a lot of the early onset stuff, the testing, tactics, techniques, all that kind of fun stuff. We've already gotten that out of the way. So we're going to hit the ground running with our trauma section on page 85. So thank you guys very much for your time. I'll make sure I'm the last one to log out. Other than that, I will see you first thing tomorrow morning. All righty?
Sir.
Thank you, guys. Anybody has any questions, feel free to open up your mic and let me know. Thank you, guys.